Hi, everyone. My name is Leah Halali, and I'm delighted to be your host for this episode of our 2025 Friday live stream series. I'm a neuroradiologist based here in Phoenix, Arizona, and one of the convener team for the upcoming virtual conference, Radiopedia 2025. Now, if you're watching this live, there are just 101 days until the conference starts. That is actually no time at all, and time will fly by. So please don't delay your registration. The sooner you do it, the quicker you'll get your confirmation through. Now, in these next 101 days, a heap of work will take place backstage to get everything ready. The conference will run 24/7 over 5 days in July. Now, during that week, you can decide how you want to experience it. You can join us for live stream sessions and chat with fellow delegates and the speakers, or you can dip in and out as you like with our on demand selection. Or you can just do what I like doing, a little bit of both. Either way, your registration will give you access to the whole week for quite a long time afterwards, too. You get 30 days if you register just for the conference, or 90 days if you have an all access pass. So, really, plenty of time to digest everything. Now, one more quick conference update. We have now sent out notifications to all our poster authors about whether or not their abstracts were accepted. The standard just keeps getting higher and higher, and we cannot wait for you to see these final posters. Okay, let's get right to today's lecture. This one is by my fellow convener, Dr. Joe Mullineux from the United Kingdom. Joe is an abdominal radiologist, and his talk is entitled Cystic Liver Lesions. And as you'll learn, there is a whole lot more than just simple cysts. And there is so much you'll learn from this talk, including what Joe's favorite refreshment is. Okay, take it away, Joe.
Hi, welcome to my session. I'm Dr. Joe Mullineux, and I'm going to be talking to you today about cystic liver lesions. So the learning objectives for today are to understand the imaging characteristics, particularly of rarer cystic liver lesions, and also want to draw to your attention some updated nomenclature around particularly mucinous cystic neoplasms. I want us to then be able to differentiate from these rarer cystic liver lesions from the more common cystic liver lesions we all know about, and consider how that has implications for the patient's diagnosis and management. At the end, we'll try and integrate these imaging findings into a broader clinical contents, referencing up-to-date clinical practice guidance, namely those published from the European Association for the Study of Liver, EASL, in 2022. When I was thinking about producing this session, I wanted to think about what theme I would produce, and I couldn't get the thought there's little tapioca balls floating around in bubble tea as cystic liver lesions. In reality, the concept of a cystic liver lesion in bubble tea is a lot less appetizing than that first image. But I rolled with it. So welcome to my bubble tea cafe, and this is the menu for today. We're going to look at a range of rarer cystic liver lesions, from ductal plate malformation related lesions all the way through to cystic neoplasms. But before we go into that section, I want to talk to you about the simple hepatic cyst, because this is by far and away the most common cystic lesion you're going to find. And they're small little cysts cleaved from the biliary epithelium during normal embryogenesis. They no longer communicate, and they have aligned with biliary epithelium and just produce serous fluids. They can slightly increase in size. Most of them cause no issues, and we ignore them daily. However, on a few occasions, these can become complex. So if they get particularly large and cause symptoms and become symptomatic, they are defined as complex. But also they can have true complexity on imaging. So that can be from infection, hemorrhage, you can see septa in it, and debris. So it's really hard then to differentiate these complex simple hepatic cysts from more worrying things that we're going to go through now. So we're going to talk about these and then talk about differentiation later on. So ductal plate malformation related cystic lesions is quite a wide group of abnormalities. But to go any further, we need to understand the embryology. So the ductal plate forms from originally bipotential cells surrounding a portal system, particularly a hilar portal system with a liver bud that then grows out from the hilum. And it forms from a single layer into a double layer, and this is the ductal plate. This then, through the normal embryogenesis process, should cleave into a nice hepatic biliary system draining into the duodenum. Now, if you have issues anywhere along this pathway of ductal plate formation, cleavage, and involution, you can form abnormalities of the bile duct, which we'll touch upon later. So the stage at which you have an issue with your ductal plate formation or resorption will dictate what abnormalities you see. So if you have an early abnormality when you affect your large bile ducts, you have an effect that has largish appearance on imaging. If you affect it in the interim stage, you affect the medium bile ducts, and your abnormalities are of a medium size. And then if you affect the small bile ducts at the end or late stage, you can have small abnormalities you can see in the liver, or abnormalities you can't see at all, so microscopic abnormalities such as congenital hepatic fibrosis. So we're going to work our way from the outside in and just touch upon some of these abnormalities. So this is a patient who had ultrasound for abdominal pain, and they had multiple cystic areas throughout the liver, and they had, you can see, some little comet tails within these abnormalities. They went on to have an MRI, so this is a T2 weighted axial MRI showing these multiple cystic liver lesions throughout the liver. If we take a closer look on fat saturated coronal T2 imaging, we can see this has a starry sky appearance against a background sort of black liver, and you have a normal biliary tree intervening. And if you note, these are all small abnormalities, less than 1.5 centimeters. So these are multiple bile duct hamartomas or multiple biliary hamartomas. They're rare incidental findings, but they can be found in up to 5.6% of autopsy. So they tend to be asymptomatic and just present and never present at all with any pathology. As I've said, this is failure of the normal bile duct involution at the late stage of embryogenesis. And you get multiple small cystic lesions less than 1.5 centimeters, and there is no communication with the biliary tree. They can be seen in isolation or associated with other ductal plate abnormalities, which we're going to go through now. Just to remember, on ultrasound, you get multiple small lesions with comet tail artifact, and on MRI, you get a starry sky appearance of the liver. So if we move to the medium bile duct abnormalities, so in the middle stage of embryogenesis, so you have some sort of interruption there, you get this type of appearance. So this is multiple cysts throughout the liver, but this time we note that some of these liver cystic lesions are much bigger, so they're much bigger than 1.2 centimeters, 1.5 centimeters. And we can see here there is a typical appearance of liver parenchymal replacement. So in the left lobe here, multiple cysts are replacing the liver parenchyma, whereas cystic masses tend to push the parenchyma away. Again, high T2 weight, you can see they're all very cystic. We've also got these cystic abnormalities in the kidneys. On post-contrast imaging, there is no enhancing internal complexity. Yes, there are a few subtle septi, but none of them are truly complex on the post-contrast imaging. So this is polycystic liver disease. Now, it can affect the liver only, and it's been called autosomal dominant polycystic liver disease, which is the rarest, about 1 in 100,000. And then you have when it affects the kidneys and the livers together, and that gives you a polycystic kidney disease, autosomal dominant polycystic kidney disease, and autosomal recessive polykidney disease, which is a bit rarer than the autosomal dominant variant. But both have polycystic liver disease as well as the kidneys. They are thought to represent cystic dilatations of biliary hematomas. They're essentially large biliary hematomas, which fits with the theory of the stage of which they're sort of cleaved off from the ductal plate malformation. You need at least 10 simple liver cysts for the diagnosis. Any less than that, you just have a few cysts in the liver. Any more than that, then you should be thinking, could this be polycystic liver disease? And these patients are more likely to end up with complex or symptomatic cysts, and often the ones needing treatment either by IR or surgeons. More common in females, and there is thought to be estrogen sensitivity. So part of the EASL guidance in 2022 does recommend stopping exogenous estrogen for these patients, particularly if they have symptomatic cysts. So now we move on to the larger bile ducts. So this is when the ductal plate abnormality happens early on in embryogenesis, that liver bud near the hilum, you're affecting the larger bile ducts. And what we see here is we have abnormalities that are connected to the biliary tree. So here we can see saccular dilatation of the biliary tree that is linear and communicating with the abnormal biliary tree. We can see here, down in segment 5, again, saccular, linear biliary dilatation with a slight dilatation of the extrahepatic biliary tree. Of note, I'm going to draw attention to this cyst here. So this is a cystic dilatation, and we can see an enhancing portal vein just there. So that's a central dot sign. This is a very specific design for this sign for this abnormality, which is Caroli's disease. Elsewhere on this study, we've also got quite good going portal hypertension with multiple dilated vessels around the splenic hilum, recanalization of the veins here, and splenomegaly. Of note, there are also abnormalities in the kidneys. This time we've got cystic dilatation of the collecting system, both medullary and papillary. So this is Caroli's disease. It's a congenital disorder affecting the large bile ducts, and it's associated with renal disorders, particularly medullary sponge kidney. You get multifocal saccular dilatation of the intrahepatic ducts, can be diffuse or sometimes segmental. And if it's segmental, that's often quite good because the patient can have a segmentectomy and be cured. But it can lead to misdiagnosis, particularly with things like cholangiocarcinoma can get misinterpreted as Caroli's disease or vice versa. With Caroli's disease, you get recurrent attacks of cholangitis, and you can get intraductal stone disease, which can be quite debilitating for the patients. About 77% chance of you have a 7% increased chance of cholangiocarcinoma if you have this recurrent sort of inflammation of the bile ducts. So it's something you have to be wary of if you have a patient with Caroli's disease. Are they developing a cholangiocarcinoma on the background? Now, we have Caroli's disease and then we have Caroli's syndrome. So Caroli's syndrome is when it combines those ductal abnormalities with that smaller at the small bile duct, you get congenital hepatic fibrosis at the microscopic level. And that's also associated with kidney disorders, particularly autosomal recessive polycystic kidney disease. Again, another ductal plate malformation spectrum disease. The symptoms from Caroli's syndromes is more likely to be with the fibrosis, and there is a thought that you often get the Caroli's affecting the smaller ducts. And you get a specific dysmorphia in the liver fibrosis where the segment 4 is spared of the normal atrophy that you would see on a cirrhotic liver. So one thing to remember is that central dot sign. So that central dot of the portal vein with the abnormal saccular biliary tree around. That's a classic for Crohn's disease. So we're going to move on now from that big section on ductal plate malformation related cystic liver lesions to other congenital liver lesions. So this is a case of a patient who had a rectal cancer. They had a staging CT scan which showed an abnormality in the liver which wasn't quite typical for a simple cyst. It was isolated in segment 4, and we did an MRI and we can see here it is a cystic liver lesion just in the subcapsular region of segment 4. On the T1 imaging, this liver lesion is iso-intense to the background liver, so it's not a typical simple cyst, which should be hypo-intense. It has some internal high T1 material, which is usually proteinaceous. Gives some contrast, again well defined. The liver lesion becomes apparent, and on the Prima-Vis study, there is no communication to the biliary tree. This turned out to be a ciliated hepatic foregut cyst. So this is a very rare incidental finding, which is found in that typical location of segment 4 in a subcapsular region. And it's thought to be the embryonic foregut. This little bit of foregut cystic material is enveloped into the liver, and it has distinct histopathology, which is how you make the diagnosis. So it has pseudostratified tall columnar epithelium, and it has 4 layers, so it includes smooth muscle as well, much like any embryonic foregut cystic lesion. So you can make the diagnosis by resection, which is recommended because of the risk of malignancy, but often we're not sure if this is a true cyst, so you can aspirate it, which shows these pseudostratified columnar epithelium on a mucin background. Something to be aware of, but it's very rare. Another abnormality which is incidental but less rare is this one. So this is a patient who had a CT, and they found some unexplained cystic lesions that were in a typical location around the biliary tree, and there was some concern about whether the patient had biliary dilatation. On MRI, we can see that there are actually separate, distinct cysts which are just situated in a peribiliary location. Just have a look at that on the coronal imaging. The biliary tree around that is completely normal. Without good quality imaging, it can be quite hard to see. So you might need MRCP sequences. Again, this one's not brilliant. And you may resort to some post-contrast imaging, which show the biliary tree separate, particularly hepatobiliary phase, late phase imaging. That can help define that these are separate from the biliary tree. So they're small serous cysts due to obstructed extramural peribiliary glands. And they can be isolated in adult autosomal dominant polycystic kidney disease or polycystic liver disease. So that's why they're in the congenital section, but they are seen in 50% of cirrhotics, so it can be acquired as well. As I've mentioned, they can be confused with biliary dilatation on CT, particularly if you're cirrhotic with abnormal liver function tests. So if you suspect this, don't do any intervention. Do an MRCP first, which is often diagnostic. And as I've said, hepatobiliary phase agents can be used to be sure that these are separate from the biliary tree. So now we're going to move on to infective causes. So the infective causes, I think the most common is a pyogenic liver abscess. And this is an example of a patient who presented fever, unwell, with sepsis. They had some air in the biliary tree, suggested they may have had a sphincterotomy before. They've got an open biliary tree, but they haven't got any, there may even be a fistula there. So we've got a reason why they have an abscess, but they haven't got a stent in there or anything. And if we look at the liver lesion, we can see it's got thick rim that's enhancing. It's got some changes on the outside of the liver in that area, suggesting inflammation, which is ongoing. The patient also had some hemangiomas, incidentally, but this was found to be a pyogenic abscess. So unlike that case, they can occasionally provide a diagnostic conundrum. without if the patient doesn't have clear sepsis, and if the abscess can look semi-solid. So sometimes you need to do further imaging or just wait, see how they go on antibiotics, and it may liquefy. And occasionally you just need to aspirate and try and get an organism. So common organisms we can isolate from these cystic liver lesions are Klebsiella pneumonia or Enterococcus and Streptococcus. If it is a cholangitic type abscess, they tend to be cholangitis tend to be smaller and multiple. However, if we feel it's coming from a hematogenous spread, maybe a diverticulitis, then they tend to be larger and big cystic liver lesions like the one I've just shown. The next case I'm going to show you is also an infective cystic liver lesion. This one is a hydatid cyst, which is caused by infection from a cestode hydatid worm, which enters the human body as an accidental host. And we can see on the imaging, this is got very clear imaging features, particularly on MRI. You can see there is a peripheral outer rim, which is low signal on T2 imaging. It probably includes some calcification, which you'd see better on CT. And then there are these internal membranes, which have a classic appearance or have been given the sign of a water lily sign. It's the flower of a water lily, and that's formed by the layers of the internal membranes falling away from this outer pericyst, and this is the endocyst within centrally. Now, this is one classic appearance, but there are multiple appearances of this hydatid disease in the liver. So we can see there are, again, this is another MRI separate patient, but there is a low T2 signal rim, again seen, possibly with calcification. And then there's this mother cyst with multiple peripheral daughter cysts around the outside. Just show you that on the coronal imaging, where you can see there is possibly also some biliary communication, which you can see in hydatid disease. On the post-contrast imaging, you don't get much contrast, but you can still see the differential between these daughter cysts and the larger pericyst, mother cyst. So this is hydatid liver disease, which I've already mentioned is from a cestode worm known as Echinococcus granulosus infection. The host animal is usually a dog gut, and then it has intermediate hosts into usually sheep, so it can be in the sheep farming community, and then enters through egg ingestion into the accidental host, the human. So these cysts can often have three layers. So I've shown you the outer pericyst. They have a middle laminated membrane and an inner germinal layer, which together are called the endocyst, and this is what forms the membranes that falls away and gives you that classic water lily sign. Complications can include biliary fistulation, and the WHO classification in 2001 gave up to 7 different stages on imaging, which we're not going to go through here, but there is a Radiopedia article covering this specifically if you want to go away and read about it. Now, calcification we do see often in hydatid cysts. Now, this can be in the active and in inactive phase. So just having calcification doesn't mean it's an inactive hydatid disease. This is the water lily sign. So just remember to take that away, those water lilies, but you can also get the classic sign of daughter cysts. Both of these are evident in the transition and active phase, and there are multiple other appearances, but these are the classic signs. So we're going to move on from infective causes now on to cystic neoplasms. So when cystic neoplasms are solitary, they are often mucin-producing cystic neoplasms in the liver. And previously, they had nomenclature that is now outdated and is obsolete. So they used to be called biliary cystadenoma, or if they became malignant, cystadenocarcinoma. Now, they often lumped these two pathologies together. However, now we can tell them apart on histology definitively and hopefully on imaging features as well. So you have a mucinous cystic neoplasm of the liver and intraductal papillary neoplasms of the bile duct, which are also within the liver. So they do have similarities, particularly in names, to the pathology of the pancreas. So MCN in the pancreas and IPMN in the pancreas. So this is a very interesting case of a young female who, on the scanograms, she has these bilateral wires of her sternum, and she had actually had a lung transplant. The reason for that is revealed on her abdomen scan because we can see she's got fatty replacement of large portions of her pancreas, so she had a background of cystic fibrosis. However, this is unrelated to this very abnormal cystic liver lesion we see in her liver. So it's occupying a large volume of the left lobe of the liver. And on coronal imaging, we can see the biliary tree is dilated, and there's a suspicion that this is communicated. So she went on to have an MRI, which is the mainstay for this diagnosis, particularly of cystic lesions. And on here we can see there is definite serpiginous communication from these bile ducts, which are massively dilated, into the extrahepatic biliary tree. And then we can see this open fish mouth appearance of the ampulla with mucin coming out into the duodenum here. So this is from mucin hypersecretion giving you a fish mouth appearance. So that is an appearance of intraductal papillary neoplasm of the bile duct. So the WHO classification was that this was a pre-malignant neoplasm demonstrating intraductal papillary or villous growth of biliary type epithelium. You get polypoid intraductal masses with associated bile duct dilatation, and 30 to 40% will have this mucin hypersecretion. Now, these lesions are thought to have higher malignant potential than their pancreatic counterpart IPMNs. So they are, the gold standard for treatment is resection, and it is good practice to do a cholangioscopy before that to find the true extent of these papillary growths, which can be quite hard to see. We didn't see on our imaging any growths, but you often do have these papillary growths in situ. And this is an example of papillary growth within the bile duct on an MRCP, and this shows another very specific sign which wasn't on my study. It's called the thread sign. So you get these linear parallel low attenuation striations which are parallel to the bile duct in a dilated bile duct. So this is a specific sign called the thread sign to look out for if you think you've got an IPMB. And the other thing, if you have mucin hypersecretion, as in main duct IPMN, you get a fish mouth appearance of the ampulla, you can get it in IPMB as well. So the next case I have is a middle-aged female presented with an abdominal mass, and this was arising from segment 4 of the liver and extending down into her abdomen, and it had multiple septations and loculations. On T1 imaging, these loculations had varying T1 signal within them, so that's not a classic appearance of a simple cyst. And then when we gave the patient some contrast, we can see that these septa and loculations did show post-contrast enhancement, and there is an enhancing rim. So this is not a simple hepatic cyst, it's complex and large. This was resected and turned out to be a mucinous cystic neoplasm of the liver. In the 5th WHO classification, these lesions were defined by having a specific stroma, ovarian-like hypercellular stroma, or OLS. And this led to the push to removing them from the IPMBs who do not have this OLS hypercellular stroma. So that's a histological diagnosis. On imaging, and this is backed up by a lack of communication to the biliary tree, whereas the IPMBs will communicate. A large majority of these are in the left hepatic lobe, particularly segment 4, and they are almost exclusively in females, often middle-aged. So if you have a male who you think has a mucinous cystic neoplasm, think again, it's highly unlikely. MCN is rare and it accounts for less than 5% of cystic liver masses. So just to bear that in mind, it is a rare diagnosis. And the final one in this group we're going to talk about is this patient who had a CT study, staging study, because they had an abnormality all the way down in their pelvis, which is a cystic abnormality of their appendix. We can see this looks like a mucinous carcinoma of the appendix. They also had an abnormal cystic lesion in their left adnexa. So going back to the liver, we can see that actually they also had multiple cystic appearing liver lesions. So the patient went on to have an MRI, and the MRI showed that these were truly cystic. On post-contrast imaging, there was one of the sequences which showed some possible rim enhancement, but on the delayed imaging, they didn't seem to have much enhancement at all, and again gave a fairly typical appearance of simple liver cysts. On diffusion imaging, there was no true diffusion, just T2 shine through from the mucinous material. So these were thought to possibly represent simple cysts and unrelated to the malignancy. However, they did go on to grow, and these were later confirmed as cystic metastases. So just remember, they're far less common than solid metastases, so that can lead to misinterpretation. They can mimic cystic, just simple hepatic cysts. Occasionally, they are due to true cystic primaries, which makes this much more common. So look at the appendix for any cystic neoplasms, and also any mucinous primary cancers, such as a mucinous rectal cancer or bowel cancer. Occasionally, very high turnover malignancies can lead to rapid necrosis within cystic liver lesions, so you can get necrotic liver lesions which appear cystic. The key here is a history of previous malignancy and any growth on imaging. So that's our bubble tea menu complete. We've gone through some rare cystic liver lesions, and I hope I've given you some key features to look out for. But what we want to talk about now is how do we differentiate these complex cysts that were simple liver cysts that we would ignore from these other rarer cystic liver lesions. The truth is it's very difficult, but I would try and use a way to go through these. So if you see a complex cystic liver observation, the first thing I'd ask yourself is there any bile duct communication? Because if there is definite bile duct communication, you have a much smaller list to think about. So you could be an IPMB with a classic thread sign, or a fish mouth sign, or it could be Crowley's disease if you have that central dot sign with saccular intrahepatic duct dilatation. Or occasionally hydatids can rupture into the biliary tree and give a very similar appearance to an IPMB. So that's one thing to think about from a clinical side. Now, if they don't have bile duct communication, then it's a bit harder to tease this out. And this could be a mucinous cystic neoplasm, although rare. It should be in a female patient, often middle-aged, and look for that typical location. And they often have these enhancing septa on MRI. And we'll talk about the septa abnormalities in a bit more detail. Or is it a complex simple hepatic cyst that has just become complex? Or could this be metastatic disease or infection? The way I deal with this is I think about infection and metastasis first, and I delve into the electronic medical record or speak to my referrer. Now, if they have any of these symptoms, think infection, particularly if they are septic. You can use imaging, so gas is very useful on imaging, and also PET-CT can be helpful if we're still not sure whether there's any infection in a cyst. The other thing you want to look into is in the history, do they have a known primary malignancy, or do they have a primary lesion identifiable on their previous imaging? So have a look through carefully. If you've ruled those out and there is no communication to the biliary tree, then you're either dealing with a complex simple hepatic cyst or a mucinous cystic neoplasm. So, what are the worrisome features when we have to start thinking about MCN? Well, I think thick septations that enhance and any enhancing nodularity are the major worrisome features, and these are referenced in the ESOL practice guidance in 2022. If they are combined with minor worrisome features, which are referenced here, then that's much more likely that this could be an MCN. But remember about it has to be in females. Another group looked at this differentiation. They looked more in detail at the morphology and particularly the morphology of septa. So if you have unilocular simple cysts or bilobe simple cysts, these were all simple cysts when they looked at the histology. If you have a septation which arises from a macrolobulation, these were all also simple cysts. So that is a reassuring sign, even if it enhances. Now, if you have enhancing septations that don't arise from this indentation from a macrolobulation, so something like this, arising from a normal wall, or a central one like this that enhances, then that is a lot more concerning for a mucinous cystic neoplasm. It's not definite that it is that, but it is just more concerning. So that's worth looking at when you look at these cystic liver lesions. So if you have a complex cystic liver lesion and you have those worrisome features or the septa look that way and you suspect an MCN, then the management really is surgical, because if you leave these and they can become malignant. So if that's an option, they are resected. This was from ESOL in 2022. ESOL also went into how do we treat these symptomatic, truly simple hepatic cysts that without biliary communication that get large. And so you can treat them either surgically if they're causing symptoms, or equally you can treat them with image guidance, aspiration, and sclerotherapy. You can use various different agents. 100% ethanol is probably the best. So radiology and surgeons are involved in the management of these large symptomatic simple hepatic cysts. In real life, though, without these guidance, what do you do with a complex cyst which is indeterminate? You're still not sure, but it doesn't have any of those worrisome features on MRI, but the patient's still symptomatic. So occasionally with these patients, you might want to do some imaging follow-up, but that will be after discussion in your MDT with your liver surgeons, and you come to a consensus. But in real life, there are lots of lesions we're not sure about. Most of them will not be mucinous cystic neoplasms, but we have to think about that in the differential diagnosis. So to wrap up, I just want to give you some take-home messages from this session. So most cystic liver lesions will be benign. And definite differentiation on imaging alone is not always possible. It can point you in the right direction, but we may need to either aspirate or resect, particularly if we're concerned about MCN, because we don't want to spread this mucinous material around the abdomen. Rarer mucin-producing cystic neoplasms have updated nomenclature, and that's all around the histopathology. They also have specific imaging findings that can aid recognition and point your surgeons in the right direction for management. And the last thing to remember is that the diagnosis and management of cystic liver lesions is heavily reliant on both diagnostic and interventional radiological input. So we are really key, especially in MDT, to help direct the management for these patients. Thank you for listening to me. I'm going to now enjoy my bubble tea while you guys enjoy the rest of the talk. So, cheers everyone. Thank you very much.
Oh, wonderful. Thank you so much, Joe. I don't know about everyone else, but I kind of feel thirsty now. Anyways, we'll let Joe enjoy his drink and a break, but not for too long. because he is super busy creating new content for Radiopedia 2025. In fact, on day 3 of the conference, he has a brand new talk about gallbladder disease, including tips on intervention. And if that wasn't enough, he also has a case set focused on prostate MRI, and he's co hosting an abdominal workshop with Vika Shah. Now, in both the case set and the workshop, you will be able to scroll through the cases while Joe shows you what to look for. And besides that, there is plenty of more lectures from world-class faculty covering abdominal and gynecologic imaging, anatomy, teaching, and of course, everyone's R posters. But that's it for today, though. Thank you for your company, and I will see you all soon. Bye.